Hello, my name is Amir. I'm pleased to say that I'm a dental surgeon. I'm actually a little dentist, working on my own in a little practice in a small town called Havant in the United Kingdom. And I'm here to talk to you, a budding dentist, a dental therapist, a midwife, a nurse, anyone, but especially you, about liver disease and hepatitis, about liver disease and cirrhosis, about liver disease and patients who are jaundice, in particular, so that you would know what to do and hopefully you would know what to say should you ever be confronted or presented in an exam situation with a patient who is jaundice. And that is the first question, isn't it? Would you agree with me that this imaginary patient whom we're going to call Mrs. Horn, a 49-year-old patient who is pretty much deeply jaundiced in that slide, is jaundiced or not? And if she were very jaundiced like Mrs. Horn is, what would you do? What would you say? But the first thing is, you tell the examiner, I would like to put my patient, Mrs. Horn, under good light. The light in June, like this morning, is very good. The light in December is not so good. And you would put Mrs. Horn under good light, and you would be looking in her eye, and you would be looking at the sclera of the eye. And in order to do that, you depress the lower eyelid and you look at the yellow staining of the sclera. You look at the sclera because the sclera is white in color and shows up very well. You tell the examiner, I think my patient is jaundice, and he will say, make sure by looking at the sclera, and you tell him that you have. And she's pretty much deeply jaundiced and evident. The examiner would then say to you, are there any other conditions where you can get a yellow sclera bar being jaundice? You tell the examiner no. I mean, there are other causes of yellow pigmentation of the skin, but they don't usually affect the sclera. They don't usually attack the sclera. The examiner will agree with you. The examiner would then refer you to Mrs. Horn and say to you, what do you think is the likely cause of Mrs. Horn's jaundice? Or may say to you, what sort of jaundice are there? You tell the examiner there are 3 sorts of jaundice. Jaundice that is caused by liver cell disease, which we call hepatocellular. Jaundice that is caused by obstruction to the liver, biliary obstruction. And 3, hemolytic jaundice. That is excessive breakdown of red blood cells. Because bilirubin, the name we give to this yellow stuff, comes largely from breakdown of red blood cells and that of hemoglobin. The examiner will accept that and will say to you, in view of Mrs. Horn's jaundice, which is pretty much severe and deep, which one of the 3 do you think is the likely cause of Mrs. Horn's jaundice? You tell the examiner that you're pretty much certain that it is either 1, hepatocellular, that is jaundice which is caused by liver cell disease, or 2, biliary obstruction, obstruction to the liver. I suppose that would be a good bet. Because the only thing you're looking at the moment is the depth of jaundice. Whether it's mild, whether it's moderate, whether it's severe. And Mrs. Horn's jaundice is severe. So it cannot be hemolytic jaundice. Because hemolytic jaundice is always mild. patients are not deeply jaundiced. They have signs and symptoms of anemia because that's what's causing the lesion. And if you were to check their liver function, it would be entirely normal. And even if you were to break down all your red blood cells, break them all down, your bilirubin level will not rise very much. Mrs. Horn's bilirubin level is perhaps 30 times the normal. So it cannot be hemolytic jaundice. So the answer, you tell the examiner, is either 1, hepatocellular, or 2, biliary obstruction. Now the examiner may now just try to trip you up a little. That's what his job is. That's what he does. And will say to you, tell me, what investigations would you now undertake to put the cause of Mrs. Horn's jaundice in one category or other? You tell the examiner, without being rude, that you would not undertake any sort of investigations at the moment, but you would merely conduct a pertinent history. In particular, you would like to ask Mrs. Horn 6 questions. The examiner will be pleased with you and will tell you to proceed with your first question. And you tell the examiner, I would like to know something about the color of Mrs. Horn's stools. In particular, I would like to know whether they're lighter or whether they're darker. And I'm afraid, in either case, whether the cause is hepatocellular or biliary obstruction, stools become lighter and there is a tendency for diarrhea. You mustn't lead the patient. Very much like the examination in chief in the High Court. You mustn't ask leading question. Have the stools become lighter, Mrs. Horn? Or have you noticed the stools become darker, Mrs. Horn? Much, much lighter. And have you noticed anything else, Mrs. Horn, about the motions? Yes. Loose, pale motions. The examiner would then say to you, well, how does that fit with jaundice? You tell the examiner, well, what color is the stools normally? Bile or breakdown product of it. Hence, if there is less bile going to the gut, hence less pigment in the stools. We don't call the pigment in the stools bilirubin. We call it stercobilinogen. But it is derived from bilirubin. That is, bilirubin is conjugated in the gut. Then you will perhaps be surprised to learn that bacteria in the gut deconjugated, turning it into stercobilinogen and urobilinogen. And then these can then be absorbed and excreted by the stools and urine, respectively. You tell the examiner that after your first question, you are still unable to put the cause of Mrs. Horn's jaundice in one category or other. Because in either case, whether the cause of jaundice is hepatocellular or that of biliary obstruction, stools become lighter. And there is a tendency for diarrhea. And therefore you seek permission to proceed and ask your second question. The examiner will tell you to proceed. You tell the examiner, since the first question was to do with the color of Mrs. Horn's stools, I would like to know something about the color of Mrs. Horn's urine, because stools and urine go very well together. And I would like to know whether Mrs. Horn's urine is darker or lighter. And so, Mrs. Horn, can you tell us something about the color of your urine, please? Yes. Much, much darker. The examiner will say to you, well, how does that fit with jaundice? You tell the examiner, well, what color is the urine normally? Again, we don't call the pigment in the urine bilirubin, we call it urobilinogen. But as I've just said to you earlier on, it is derived from bilirubin. But the point about obstructive jaundice and that of hepatocellular jaundice, there is actual bile pigment in the urine, so the urine becomes much, much darker. And therefore you tell the examiner that after your second question, you are still unable to put the cause of Mrs. Horne's jaundice into one category or other. Because in either case, stools become lighter, urine becomes darker, and there is a tendency for diarrhea, as exhibited by Mrs. Horne's response. And therefore you seek permission to proceed and ask your third question. The examiner will tell you to proceed. You tell the examiner, I would like to know whether or not Mrs. Horne has developed an itch in any part of her body, and if she has, something about its intensity, duration. The examiner will say to you, what is the relevance of that? You tell the examiner that itch is just an irritation of the skin due to high bile salt concentration. They deposit them underneath the skin, and patients find itching even more distressing than being yellow, and that usually implies you're dealing with obstruction to the liver, biliary obstruction. And so, Mrs. Horne, can you please tell us whether or not you have developed any itch in any part of your body, and if you have, something about its intensity, duration, something about it? Yes. In the past 3 weeks, I've been itching all over, especially around my shoulders, and I find itching even more distressing than being yellow. Thank you, Mrs. Horne. You told the examiner that after your third question, you are perhaps 25% swayed towards the cause of Mrs. Horne's jaundice as being due to obstruction to the liver, biliary obstruction, because of the itch, because of these high bile salt concentrations. And therefore you would seek permission to diversify now and proceed by asking your fourth question. The examiner will tell you to get on with it and proceed and diversify. You tell the examiner, I would like to know how all this started. The onset. The examiner will say to you, why? You tell the examiner, because patients with hepatocellular jaundice, liver cell disease jaundice, where every liver cell is affected more or less at the same time by the same thing, be it a virus, be it a drug, the jaundice is of sudden onset. Whereas if you were to be operated on this morning and the surgeon were to tie off your bile duct, it would take several days before you became jaundiced, and a week or two before you became deeply jaundiced, like Mrs. Horne. So the onset is desperately important. Sudden onset, hepatocellular. Gradual onset, biliary obstruction. Light stools, biliary obstruction and hepatocellular. Dark urine, biliary obstruction and hepatocellular. Itch tends to sway you towards biliary obstruction. And so, Mrs. Horne, can you please tell us how you first discovered that you were jaundiced? Yes. A friend of mine, Nancy, a good friend of mine, pointed it out to me over the garden fence. She said that in the last week I was gradually becoming more yellow, and today she said I looked like a canary. So I went to see my doctor, and he didn't even bother looking in my eye and said to me that I was deeply jaundiced. You tell the examiner that after your fourth question, because of this gradual onset, because of the itch, because of the light stools, because of the dark urine, you are now 70% swayed towards the cause of Mrs. Horne's jaundice as being due to biliary obstruction. Obstruction to the liver, and therefore you seek permission to proceed with your fifth question. The examiner will tell you to proceed. You tell the examiner, I would like to know whether or not Mrs. Horn has developed any abdominal pain or discomfort recently. The examiner will say to you, why? You tell the examiner, because I would like to rule out inflammatory things and things like gallstone and things like that. And so, Mrs. Horn, can you please tell us whether you have developed any abdominal pain or discomfort? And if you have, can you please tell us a little bit about it? Yes. The past 4 weeks, I've been having pain here. My doctor calls it the liver, the right hypochondrium. It's not so much pain, it's discomfort. It's not so much discomfort. I feel bloated. Thank you, Mrs. Horn. You told the examiner that after your fifth question, you're still 75% sure that the cause of Mrs. Horn's jaundice is due to obstruction to the liver. Biliary obstruction, and therefore you seek permission to proceed with your final question. The examiner will tell you to proceed. You tell the examiner, I would like to know whether or not Mrs. Horn has had any weight loss. The examiner will say to you, why should patients with jaundice lose weight? You tell the examiner, because they have malabsorption of fat. They have a thing called staturemia. That just means a flow of fat. And together with being off your food, anorexia means patients who are jaundiced lose weight. In fact, most patients who are jaundiced lose weight. And so, Mrs. Horn, can you please tell us whether or not you've lost any weight recently? And if you have, can you tell us a little bit about it? Yes. I've gone from 68 kilograms to 61 kilograms. I've nearly lost a whole stone. Thank you, Mrs. Horn. You tell the examiner that after your sixth question, you are pretty much certain, 75% sure, without having done any sort of investigation, that the cause of Mrs. Horn's jaundice is due to obstruction to the liver, biliary obstruction. Now, the examiner may have just had enough from you and may just want to bring you down a peg or two. And will refer you to Mrs. Horn, whom you have said that there's a 75% chance that the cause of her jaundice is due to obstruction to the liver. But instead of asking you about biliary obstruction, the examiner may ask you a question just a little bit below the belt. A simple enough question. Will say to you, tell me how bilirubin is formed, and tell me about the different forms of bilirubin. And that's usually enough to bring everyone to their knees. So let me remind us. There is a red blood cell and erythrocyte born and bred in the long barrel. Why a process known as erythropoiesis. And red blood cells do not go on living forever. They have a lifespan of 120 days, and after that is breaking down, and is breaking down, releasing this substance we call hemoglobin. So the real question should have been, how do we go from this hemoglobin, which is a 4-ring arrangement, a cyclic tetrapyrrole, to bilirubin? Again, a tetrapyrrole, but arranged in a linear fashion. So something dramatic must have happened to have allowed this. And the first thing that happens is that the iron of the hemoglobin goes. Then the globin part goes, leaving this skeleton, this ring structure. This ring is then broken down at one of these points and unrolled, just like a sausage roll. And that is an enzyme, which is responsible for this unrolling effect, as it were, the hemooxygenase enzyme, which is found in the reticular endothelial system, that is the spleen and the lymph nodes. So the vast majority of bilirubin comes from breakdown of red cells and is changed from a compound like that by removing the iron, by removing the globin, which are then recycled and turned into this yellow stuff we call bilirubin, because this ring is broken down at one of these points and unrolled by the hemooxygenase enzyme, just like a little sausage roll. Dramatic, clever, but that's how it is. Now that's ordinary bilirubin. You must remember something about bilirubin. It exists in two forms, doesn't it? Conjugated and unconjugated. Roughly, the difference between conjugated and unconjugated bilirubin is that unconjugated bilirubin is toxic and can injure cells and can kill cells in high, very high concentration, particularly that of the brain cells, neurons, and babies with high level of this compound in the blood have a disease called connectress and may very well die. So what do? We conjugate it, we join it with another chemical in the liver, and we make it water soluble. So it cannot penetrate into cells, so it cannot damage cells, and then it can be excreted. So let's quickly go over that again. There are two forms of bilirubin, conjugated and unconjugated forms of bilirubin. Unconjugated bilirubin is toxic and can injure and damage cells. So it's very reasonable that hemolytic jaundice, where there is lots of unconjugated bilirubin in the blood, is never severe. So what do? We conjugate it, we join it with another chemical in the liver, the glucogenic acid, and we make it water soluble. So it cannot damage cells, it cannot penetrate into cells, and then it leaves the biliary tree to be excreted. And the biliary tree at this point consists of little canals called the biliary caniculi. So that's all we have to know about bilirubin, something about how it's formed, something about conjugated and unconjugated forms of bilirubin. If we did not conjugate bilirubin, we would all be permanently jaundiced, permanently yellow, and we would all die of brain disease, connectress. There is an animal called the gun rat, which cannot conjugate bilirubin at all. So what color is it? It's yellow. Does it die early? Yes, it does. It dies for two reasons. Firstly, because of brain disease, connectress, and secondly, because you lot, doctors, are so interested to follow his unique bilirubin metabolism. You kill it early because it's a classical model. So bilirubin in the gut is conjugated. And you will perhaps be surprised to learn that bacteria in the gut deconjugated, making it into stercobilinogen and urobilinogen, and then these can be absorbed and excreted by the stools and urine respectively. The examiner will come back to you again now and refer you back to Mrs. Horn, whom you have said that there is a 75% chance that the cause of her jaundice is biliary obstruction. And will then say to you, tell me a little bit about biliary obstruction in your own words, briefly. All you know about it. You tell the examiner, well, we divide biliary obstruction into two, don't we? Extra and intrahepatic biliary obstruction. Now the extrahepatic biliary obstruction is different, isn't it? Because it is surgically or endoscopically accessible to treatment. So you can remove cancer surgically or cannulate into the tumors and deal with them in that sort of way. But if the obstruction is further up, in the liver itself, in and around those biliary caniculi that I showed you earlier on, then you can't do that. So it's important to remember that some forms of biliary obstruction, intrahepatic biliary obstruction, are not accessible to surgery. And you remember the causes of intrahepatic biliary obstruction, well, at least one of the causes, and if you really want to impress the examiner, two of these causes of intrahepatic biliary obstruction. And the first thing which comes to your mind is drugs. There is about 15 or 20 different drugs which are known to be associated with intrahepatic biliary obstruction. Drugs such as gabapentin for nerve damage, azathioprine, cyclosporins, even antibiotics like amoxicillin and chlorogenic acid, even antidepressants like tricyclic antidepressant. But the picture is a biliary obstruction, and it may mimic a cancer, a hepatoma, a malignant tumor of the liver cell, and you may wrongly suspect that you're dealing with a terrible killing disease. But all they have done is taken one of these drugs which are known to be associated with intrahepatic biliary obstruction. The second sort of things which are responsible, which can cause intrahepatic biliary obstruction are, we are back to square one again. Viral hepatitis. Viral hepatitis causes hepatocellular jaundice. But in some people, for some reason, instead of doing that, the picture is a biliary obstruction with itching and obstructive jaundice. So viruses of hepatitis can cause intrahepatic biliary obstruction in some people, and that's the snag. The examiner will then come back to you and say, well, tell me a little bit about the other two that you've ruled out, the other two causes of jaundice. Tell me a little bit about hemolytic jaundice. In your own words, very briefly. You told the examiner that is just excessive breakdown of red blood cells. Because bilirubin, as we've discussed, the name we give to this yellow stuff, comes largely from breakdown of red blood cells and that of hemoglobin. Hemolytic jaundice is never severe. Hemolytic jaundice is always mild. Patients are not deeply jaundiced. What they do have is signs and symptoms of anemia, because that's what's causing the lesion. And if you were to check the liver function, it would be entirely normal. The problem is that the liver is overloaded with breakdown of hemoglobin. So it tries to conjugate as much of it as it can, and it succeeds, and it does very well, and we are very grateful for it. But some of it remains unconjugated. And if you were to examine the abdomen, I know you don't examine the abdomen, but if you were to examine the abdomen, you will notice that in the upper left abdomen, in the left hypochondrium, a structure, spleen, is often enlarged, a condition we call splenomegaly, an enlarged spleen. And so it turns out that if you were producing enormous amount of bilirubin due to red cell breakdown, the liver cannot cope, and therefore tries to excrete as much of it as it can. And it's a significant fact that patients who are hemolyzing and producing lots of bilirubin actually form gallstones, which can obstruct the biliary tree. So you get grafted on signs and symptoms of obstructive jaundice. The examiner will be pleased with you and then will say to you, well, tell me about the other cause of jaundice that you've ruled out. Tell me about hepatocellular jaundice, liver cell disease jaundice. Briefly. You tell the examiner that is divided into two parts, isn't it? Hepatocellular jaundice. That is, there are patients with hepatocellular jaundice, with liver cell disease jaundice, where the hepatocytes, where the liver cell is entirely normal. They still get jaundice. And this is a genetic, inborn error metabolism. And though rare, it's extremely common. I suspect if we were to measure the serum bilirubin of 20 of you watching this morning, there would be a considerable variation. And in some of you, it may be 2 or 3 times higher above what we call normal. We call those congenital hyperbilirubemia. And one important group, particularly is young men, is called Gilbert's disease. They come along saying that they are mildly jaundiced. So Mrs. Horn could not be suffering from Gilbert's disease. Worldwide, it is the most commonest cause of jaundice. 5% of normal males have a raised serum bilirubin. But the most important cause of hepatocellular jaundice is some sort of a cellular problem, which can either be acute or chronic, which you might say. And if it's acute, we call it hepatitis. And if it's chronic, we call it cirrhosis. So the examiner may now come up to you and say, well, tell me a little bit about hepatitis and give me an update on the viruses that are involved. You tell the examiner you're concerned with the inflammation of the liver cell, the hepatocytes. So the 5 cardinal signs of inflammation are present. Inflammation, gore and carnage and heat and redness and swelling and loss of function and pain. And the viruses that are involved. Well, we all know about virus A, which we used to call ordinary infectious hepatitis. Virus B, virus C, the post-transfusion type hepatitis, the delta agent, virus D, and the enteric form, virus E. They all exist. They all cause hepatitis. But before I go on telling you about these viruses, I should just perhaps remind you that there are other viruses which can cause hepatitis, and you recall me telling you that when I was talking to you about glandular fever, infectious mononucleosis, the Epstein-Barr virus, in which patients can become febrile and jaundice. So let's concentrate on virus A. It hasn't got much relevance to the dentist or the dental therapist. It's a very small spherical particle, 28 nanometers in diameter. Its genome is RNA, and it's not even an enveloped virus. Yet, it is extremely stable. How do we know that? Because it can survive seawater, contaminate fish, and therefore contaminate us in turn. 65% of patients with virus A are asymptomatic. They don't even know they've had this virus. Is hepatitis A virus serious? Is it harmless or is it harmful? Well, it's harmless long term, though patients at times feel desperately ill, desperately sick. Have you had virus A? Yes. Especially if you're from Africa, 25% of young people have had virus A, and if you're from overseas, that figure is much, much higher. We used to call it ordinary infectious hepatitis and is spread by poor hygiene, contamination of food, contamination of water, poor sanitation. How do you know somebody has virus A? Well, you look for the appropriate antibodies, immunoglobulin M antibodies, IgM antibodies, and providing the better, we can leave them alone. Some people get it much more worse than others. So let's now concentrate on virus B. This is a different kettle of fish altogether to that of the virus A. It's very much relevant to dentists, dental therapists, hygienists, nurses, and doctors. Its genome is DNA. Unlike the other hepatitis viruses, which are all genome or RNA, this is a DNA virus. Is hepatitis B virus serious? Yes, it can be. Mortality rate is 10% or so in epidemics, reasonably high, and not can it only produce chronic disease and chronic hepatitis. Some patients can become chronic carriers without contracting the disease, without producing liver disease. Now I'm going to talk to you a little bit about the structure of this virus. As I said to you, it's a DNA virus. And if it's a DNA virus, it must have the protein, the polymerase, in order to replicate itself. So it can cause damage and carnage. And indeed, the DNA of the virus and its polymerase, the protein, are in the nuclear capsid of the virus. That in turn is covered by the core antigen. That in turn is covered by the little e, the early antigen. And on top of that, we have the surface antigen with these mushroom spherical-like structures poking out of it. And when the hepatitis B virus invades the body through blood, through body secretions, through body fluids, it doesn't just target any old cell. It has a specificity against specific binding sites on the liver cells, on the hepatocytes, and it latches itself on these binding sites and it enters the hepatocytes via a process known as endocytosis. As soon as the virus is inside the hepatocytes, alarm bells start to ring. We've been invaded. There is an intruder inside. They're not just going to sit back and take this. They're going to send virus-specific cytokines into the bloodstream, little perfumes, little sonic waves, which in turn switches on the T lymphocytes to the liver in order to rescue the situation. This is the acute phase of hepatitis B virus. The T lymphocytes arrive at the liver, but they can't find the virus because the virus is inside the cell. They have got their big heavy hammers and they can't find the virus, so they start breaking the hepatocytes in order to get to the virus. As soon as the phospholipid cell wall of the hepatocytes is damaged and opened, the content of these hepatocytes are released into the bloodstream. The enzymes, one in particular is alanine aminotransferase, ALT, and the other one is aspirate aminotransferase. But it is the alanine aminotransferase which we can measure and say that this patient is in acute phase of hepatitis B virus. So let's talk about the risk groups. As I said to you, blood and secretions, blood and body fluids. So that intravenous drug abusers, because of contaminated syringes, because they share syringes, hemophiliacs because of factor VIII against syringes, that has stopped now because we routinely test the blood and the positives are thrown out. Renal dialysis, staff and patients again are at risk because of syringes, because of contaminated items. And if you've been to safari in Africa and you've gone into labor or you've had a road traffic accident and you've had transfusions, you may contract the hepatitis B virus that way, because in Africa they do not routinely test the blood for the hepatitis B virus. And in institutions, mentally handicapped institutions, where hygiene, for some reason or other, is poor. And prostitutions, because of semen. Homosexual activity, heterosexual activity, any kind of sexual activity where there is an exchange of body fluids, you can contract it that way. It is not a disease of dentists, doctors, nurses, and health workers, and the chances of you picking it up is very remote. So that blood and hemophilia, blood and renal dialysis, blood and transfusion, blood and dialysis, semen and prostitution, semen and homosexual and heterosexual activity. That is how it all fits together. How do you know somebody has virus B? Well, you look for the surface antigen, the hepatitis B surface antigen. There's something else you look for though. You look for the little e, the early antigen. And why would you do that? Because it tells you whether the patient is infected. So the examiner will come up to you and say, how do you know this patient has virus B and is a danger to you? You say, I look for the surface antigen, the hepatitis B surface antigen, and for infectivity, I look for the little e antigen, the early antigen. So let's now concentrate on the viruses which we call the non-A and B, and the first one is C, very similar to virus B in that it has the same risk group and the same complications. Its genome is RNA, even more so, because it is reckoned that 50% of patients with virus C go on to develop some sort of chronic disease. Worldwide, it is a very important cause of cirrhosis. Worldwide, it's a very important cause of what we call post-transfusion type hepatitis. Let's now concentrate on the other non-A and B, which we call virus E. The enteric form, its genome is RNA again, and is very similar to virus A, found in Asia and the Far East. So you say to yourself, it's harmless, and indeed it is harmless, unless if the patient is pregnant, but it is anything but. So there are two pairs, very similar to each other. So A and E fit very well together, and B and C fit very well together. So if you remember A, you'll remember E. And if you remember B, you'll remember C. So where does D come in? Well, D stands for the delta hepatitis. And the importance of this is that it's an incomplete virus. And it can only exist where another virus exists, and that is with virus B. So you never find virus D by itself, you always find it with B, and if you have a joint infection, that's pretty bad news. It can occur acutely or chronically, that is somebody with virus B and can pick up virus D, and if that happens, as I said to you, this is bad news. You can develop chronic disease much, much more rapidly, and you could very well die. Virus B and C are also known for the neoplastic complication worldwide of what we call hepatoma, a malignant tumor of the liver cell. Now, before I leave you these viruses, just remind you again that other viruses can cause hepatitis, and I was telling you that when I was talking to you about glandular fever. 10 to 20-year-olds, they come along, and some of them have got jaundice, and they're febrile. Now, this is acute liver disease. It is perfectly possible to have chronic liver disease, and then usually we're dealing with a disease called cirrhosis. Have you seen cirrhotic livers? But there is a slide of a cirrhotic liver. From an autopsy, you can see the liver is pale, nodular, and this is certainly due to alcohol, and the army service and the tattoos and all these things all suggest the same thing. There is a slide from another cirrhotic liver, but the nodules are big like that, and we've discussed the possible etiology of that, either previous virus B or C. And if I were to tell you that this patient has had a road traffic accident and has had many, many transfusions, which one do you think it would be? Yes, virus C, because you know we routinely test the blood for virus B and positives are thrown out. Whereas we have not got a satisfactory 100% test for the virus C. Worldwide, virus C is important cause of what we call post-transfusion type hepatitis. Usually in the old days it was virus B and C, but these days it is virus C. Now cirrhosis is divided into two types, isn't it? Finely cirrhotic or micronodular, and sometimes the nodules are big like that and we call that macronodular. And it would be fairly easy to work out to yourself, well, some of these nodules may turn malignant because they're proliferating, and therefore it would be easy to understand why hepatoma, a malignant tumor of the liver cell, is an important complication of cirrhosis. Now, the importance of cirrhosis to you and me is that it is associated with a number of complications. Complications which may come across our way. And probably the most important complication to us is that the patients may bleed. So anyone with jaundice and hepatitis may bleed. Anyone with jaundice and cirrhosis may bleed. And the reason why they're going to bleed is in two folds. Firstly, because you know all blood clotting factors are made and processed and manufactured in the liver. And vitamin K, if you remember, is a substance present in the diet which normally activates these blood clotting factors, preparing them so that they stop the blood from not clotting. And the ones that are particularly important are the ones which are vitamin K dependent. And those are factors 2, factors 7, factors 9, and factors 10. So anyone with jaundice and cirrhosis may bleed. That is the reason, number one reason. The second reason is because they have a low platelet count. Because of the very large spleen many of these patients often have. The other reason why you and I should know about chronic liver cell jaundice is that patients may go into what we call hepatic encephalopathy, liver cell failure. And there are 3 important things that happen in liver cell failure. Patients are usually jaundiced to start off with. Secondly, they get fluid retention and edema. And thirdly, they may go into coma or become very sleepy, drowsy, disoriented. We call that, as I said, hepatic encephalopathy. All those things are important from our point of view. So if you have a patient who is sitting in your dental chair, who is jaundiced and on questioning, it sounds like chronic liver cell jaundice, they may show signs of hepatic encephalopathy. They may be drowsy. They may have swelling of the ankles. They may have swelling of the abdomen, ascites, and they will probably bleed. So what else happens in patients with jaundice? Well, patients develop bone disease as a result of chronic jaundice because of failure to absorb another fat-soluble vitamin. Vitamin D, again, a fat-soluble vitamin like vitamin K. So if fat is absent, if you have statorrhea, just means a flow of fat, malabsorption of fat, you may get into trouble with the bones. You may thin the bones, which may lead into fracture. Some patients, as a result of deep obstructive jaundice, develop renal failure, kidney failure, and that's a very serious complication. Patients with jaundice, we've said that, they develop an itch. This is just due to high bile salt concentration. They deposit them underneath the skin, and that usually implies you're dealing with obstruction to the liver, biliary obstruction. Some patients with deep jaundice, chronic jaundice, may go night blind, again failure to absorb another fat-soluble vitamin, vitamin A. And so, finally, it turns out that if you have a patient with jaundice, you say to yourself, what's in it for me? I'm the dentist, you're the dental therapist, what's in it for us? Well, the first thing is that the patient, you could have a viral hepatitis. So I must take all the precaution, I must protect my next patient, my nurse, myself, and my patient, and vaccine is possible for virus B, careful techniques, careful disposal of sharps, and the patients are going to bleed. So the prothrombin time must be measured and corrected with vitamin K, and don't forget, they will have a low platelet count. But most of all, anyone with hepatocellular jaundice is a candidate for liver cell failure. As you recall me telling you earlier on, 3 important things happen in liver cell failure. They're usually jaundice to start off with. They get fluid retention or edema, so if they're lying in front of you surreptitiously, look at their ankles to see whether they have ankle swelling. You surreptitiously look at their abdomen to see whether they have ascites, an enlarged abdomen. And they will probably bleed. So you mustn't take any teeth out. Because if you did, they will probably bleed to death. And you mustn't give them any sedation. Because if you did, they won't wake up again. I hope this has been useful. This is an elementary and very simple talk about hepatitis and liver disease. If you like it, please subscribe.